Hello and welcome to the Nursing Care Plan Workshop, Part 1. As a new nursing student, it's important that you start to develop certain habits, habits that you start with in the very beginning of your program and hopefully keep throughout your program and well into your nursing career. One of them is the ability to quickly assess and understand the needs of your patient and plan your care around the needs of your patient. And the care plan process is the way that we help you formalize that way of thinking. So I'm sure you've heard if you've done any research on nursing school, you've read up a little bit about this or will in the future, but nursing care plans have been around for a very long time. The intent of this is to help you establish habits and ways of thinking formally in school so that when you get out there working with real patients, it becomes just a natural part of the way that you think. So why do we have care plans? So they provide a direction for care of the client. Absolutely. It's a plan, just like it says. And the idea is you are gathering information and deciding how to best care for your patient. They also support the continuity of care and keep things in real-time information. In long-term facilities, you will typically find these formal written care plans because the patients are there for a longer period of time, and there needs to be a plan to continue and care for them over that period. In the acute care setting, you may not see a formal care plan in the chart. It then becomes just a natural way that the nurse thinks on their feet every day. They also help in school teach you about documentation, teach you to formally put into writing and verbalize what you're doing and why you're doing it. They can serve as a guide for assigning staff. For instance, as a charge nurse, if you were to look at the care plans for all of your patients, that helps you understand the acuity level or how serious they are and how many nursing staff and what types of staff you may need to care for them. And they do serve as a guide for reimbursement. We live in a world now, thankfully, where nursing care is part of reimbursement to hospitals and facilities. And so it's a way for us to document what it is that we're doing for patients. And for you guys, as I mentioned, the most important part of this process is that you are developing a method, a very strategic and consistent method for pulling information together so that you can think critically and problem solve. When you get out there on the floor, when you're out there taking care of patients, this allows you to continue this process without formally writing it down. So all of this is based on the nursing process. Now you're going to be learning about that very early on in school. So you may not completely understand what the nursing process is now, and that's okay. But we want to be sure that we at least go over it briefly so that you can understand what a care plan is about. So in the nursing process, there are these very distinct steps: assessment, diagnosis, outcome identification and planning, implementation, and evaluation. You will see this over and over again. Many textbooks use this format to teach you about diseases and diagnoses and nursing care. You'll see this as you go through different processes in the lab, and it never hurts to fall back on this. When you're trying to decide what to do, how to answer a test question, how to proceed in a clinical or lab environment, always fall back on this. It really is the foundation for our practice. Assessment is the collecting, validating, and inferring information. So, getting all of the data about your patient that you're going to need to make decisions. Nursing diagnosis is a very formal thing that we do. It's not the same as a medical diagnosis, and we'll talk about that in a bit, but there are formal nursing diagnoses that we use, and we identify actual and potential problems and put them into writing in a formalized way. Based on that diagnosis, then we look at what do we want to see happen? What are the outcomes and the goals? What do we want to see change or stay the same based on the concerns we have about our patient? Implementation is just that. It's the interventions, all of the things that we do for our patients while we're taking care of them. And we do want to support that with a rationale or evidence. And then the evaluation. So, based on the outcomes and goals, the things that we want, once we've completed those implementations, how do we know whether or not what we did worked? Did it work the way we wanted to? Did we reach those goals or didn't we? So let's put this in a context that I think all of you will understand. This is the way I would like you to think about the nursing process. We've all done things similar to this. So let's say you wanted to host a party. And so let's say my son was leaving for active duty in the military, and I wanted to host a party for him and celebrate him. So the assessment piece, the data that I've collected is that he's leaving, and that's what I know is going to happen. My diagnosis is that I have a need for honoring and celebrating and socializing with him. That's the problem that I have presented to me right now. The outcome is I want the attendance to be good. I want guests to enjoy themselves. I don't want anyone to get hurt. And I definitely want my son to feel like he's celebrated and to enjoy himself and benefit from the event. The implementation, then, if I'm looking at those outcomes to drive my implementation, if I wanted the attendance to be good, then I need to be sure I schedule it during a convenient time and place, and that invitations go out soon enough so that people can attend. If my outcome is that I want the guests to enjoy themselves, then I want to be sure that the entertainment is appropriate and the food is appetizing. If I want to be sure that no one is going to get hurt, then some of the interventions will be to remove hazards, make sure the food is cooked and stored appropriately so that no one gets sick. And if I want to make sure that my son is feeling celebrated, some of the things that I can do, my interventions might include giving all of the guests an opportunity to speak and honor him, or to sign a card or something like that. When we get to the evaluation, now the event is over and I'm trying to evaluate, did we meet the outcomes and the goals that we set forth in the beginning? If I'm looking at attendance, I can say attendance, the evaluation of this being successful, I'd like to see that 90% of people attend. If I want to think about how will I know if the guests enjoy themselves, well, the majority of the guests were laughing, dancing, smiling, or maybe they verbalized that they were having a good time. If I want to evaluate whether or not someone's going to get hurt or got hurt, I would, of course, want to see that there were no injuries that occurred during or just after the event as a result of being there. And if I wanted to evaluate how my son felt, then I would probably look at his verbalization to me of appreciation or the way that he described the event for us. So, evaluation in this text is thinking about how will I know that I've reached the goals. So, keep in mind that party planning, the same thing could be said for fixing dinner and looking at the assessment of what you have on hand and what you'd like to eat. And then the diagnosis might be that you were, missing certain items. And then outcome and planning, of course, includes making sure that all of the things you want to see happen during the dinner or what you would like to have prepared at the end. Implementation is doing all of the things that you would do to make that dinner happen. And then your evaluation criteria, of course, will be based on things like did it taste well and did people enjoy it? So starting at the beginning, we have assessment. It's pretty straightforward. You can get assessment data from lots of different places. The health history and interviews, so questions you've asked, things that you read about in the chart. What kind of things is the patient at risk of because of their past medical history? Medical record review. Lots of information can be found by looking through the chart. And then, of course, your own physical assessment, things that you find when you're listening to their lungs and their heart, and you're watching them speak and walk, and you're looking and listening and assessing them. So there are lots of places that we get data, and you use this data to decide what potential or real problems exist for your patient. This is the cornerstone of everything else that has to happen. So a little bit about the nursing diagnosis. This is something that matters, I think, because it's part of our profession. And we had this need for nursing back during World War II. Nurses were out in the field. They were working side by side with physicians. They were oftentimes working almost at the same level as a physician. They were desperately needed and their skill level was important. But they came back from the war and suddenly the world sort of wanted to put them back into that into that world where they were dominated by physicians and they were in traditionally defined female roles and their status was reduced. So this sparked this interest in wanting to turn nursing into a true profession. We wanted to earn that professional status. So we had this need to establish ourselves as a profession, but we also needed a standardized language for describing how we made our care decisions. It was all about saying we're not just following orders. Sometimes we're really good at deciding what needs to be done for this patient, and within the scope of our practice, we should be able to make those decisions and act accordingly. These are established boundaries. There are established boundaries between medical and nursing diagnoses. That's really important. We do not make medical diagnoses. So a nursing diagnosis would not be something like pneumonia or congestive heart failure. Those are medical diagnoses, but we'll talk in a minute about the differences between those. So in terms of our history over time, the nursing diagnosis was seen as an approach. This is a way that we can put a frame of reference and we can determine what to do and what to expect in a clinical practice situation. And so in the mid 50s, the term nursing diagnosis was first established to describe a step necessary in developing a nursing care plan. In the 70s, New York State was the first state to identify diagnosing as part of the legal domain of the professional nurse. And also, we had the first legislative act to recognize nurses' independent role in the diagnostic function. In the 70s, or I'm sorry, that was in the 70s. Later in the 70s, in 1973, the development of the nursing diagnosis formally began, and the American Nurses Association standards of practice, including diagnosing as a function of professional nursing. It was subsequently incorporated into the nursing process. In the 80s, the American Nurses Association released a statement that defined nursing as the diagnosis and treatment of human response to actual or potential health problems. That's when NANDA, which is the North American Nursing Diagnosis Association, was established. And in 1990, NANDA approved an official definition of a nursing diagnosis. And that definition is as follows. Nursing diagnosis is a clinical judgment about individual, family, or community responses to actual or potential health problems and life processes. Nursing diagnosis provides the basis for selection of nursing interventions to achieve outcomes for which the nurse is accountable. It's not a definition that you need to memorize, but I want you to think about that statement and the significance of that and how far we've come in our profession. It is not a responsibility to be taken lightly. In 2002, NANDA changed its name to NANDA International, or NANDA I, and that was just to reflect that we now have a worldwide interest in nursing diagnoses. And as of 2018, there have been 224 approved nursing diagnoses that are used for clinical use testing and refinement. So we talked for a minute about a medical diagnosis and a nursing diagnosis, so it's important to understand the difference. You can see on the screen, medical diagnoses might be pneumonia, but a nursing diagnosis could be ineffective airway clearance. Now, for you at this point in your nursing courses, you may not understand completely the difference, but just start thinking about that. Diabetes is a medical diagnosis, but risk for unstable blood glucose is a nursing diagnosis. So we are looking at the problems associated with the nursing diagnosis and establishing a statement about that so that we can develop a plan. So for example, during the assessment, the nurse may recognize that the client is feeling anxious or fearful and is having difficulty sleeping. Those are the kind of problems that are labeled with nursing diagnoses. So anxiety, fear, disturbed sleep pattern. Also, a nursing diagnosis refers to one of many diagnoses in the classification system established by NANDA. So it's based upon the response of the patient to the medical condition. It's called a nursing diagnosis because these are matters that hold a very distinct and precise action that's associated with what we need to do and the autonomy that we have to take specific action based on a specific disease or condition. This could be physical, mental, spiritual. Our responses are based on these diagnoses. So it's about establishing our right as nurses and our ability as nurses to look at a situation, look at the medical diagnosis and everything we've assessed, and establish a problem list or a list of nursing diagnoses on which we need to act. A medical diagnosis, on the other hand, is made by a physician or advanced healthcare practitioner, and that has to do with the disease, medical condition, or pathological state that only they can treat. Moreover, because of experience and know-how, their specific and precise clinical entity, might be the possible cause of the illness, will be taken care of by the physician. So, providing proper medications to cure the illness or ordering surgery, those are the things that are treating the medical condition that the physician or the provider is looking at. Things like hepatitis, kidney disease, etc. Usually the medical diagnosis doesn't change, and we follow orders and fill orders from the physician based on that. But a nursing diagnosis may change throughout the care of a patient, even within a day. So sometimes it's called a problem list, but the nursing diagnosis basically, these are clinical judgments that we make about actual or potential individual, family, or community problems or experiences. It's a clinical judgment. That's important to understand. It's a big responsibility. And the purpose of the nursing diagnosis, it identifies priorities, helps us direct our interventions, helps us formulate expected outcomes so that we're sure that third-party payers are coming in. So a lot of what we're doing actually is linked to insurance and reimbursement. It helps us identify how a patient or a group responds to the problems that they're having, the potential health or actual health and life process problems. And it provides a common language so that when we're speaking to each other about what's going on with our patient, we're all speaking the same. It gives us a way to evaluate and determine if the care has been beneficial and cost effective. And for nursing students specifically, the most important thing to remember is that this is a really good tool. It helps you sharpen your problem solving and critical thinking skills. Doing this over and over again throughout your schooling will definitely help you think like on your feet when you get out there. So the nursing diagnosis really has three parts, and depending on what type of diagnosis, some may have only two parts, some even have one, but in school, you're pretty much going to have nursing diagnoses with two or three parts. There's the problem, the etiology, and the signs and symptoms. As you see, the statement on the screen, acute pain related to tissue ischemia as evidenced by statement of I feel severe pain on my chest. So here's the problem. We see they're in pain. We know what it's caused by. In this case, it sounds like it's a heart condition. And we know that pain exists because the patient's telling us it's there. While this seems really simple, having those parts of the statement are very important. This defines everything else that we do. The problem, or the first part of the statement, or what you might call the diagnostic label, it defines or describes the client's health problem or response. This is what kind of triggers whatever therapy or nursing intervention is going to be determined. It usually has two parts, so a qualifier and focus. So for instance, you might have we have acute pain in the example, but in some cases, we might have the focus of the diagnosis, for instance, is fluid volume or gas exchange, but we have a qualifier. So let's say someone has pneumonia, and because of that, they're on oxygen, they're having difficulty breathing. The focus of our diagnosis is on their gas exchange, their ability to get oxygen in and carbon dioxide out. And what is wrong with that gas exchange? It's impaired. So while we don't usually talk in terms of qualifiers, when you're writing it out, I just wanted you to know kind of what the parts were. So the qualifiers are just words that are added to some diagnostic labels, to some problems, not all, and they just give additional meaning, or sometimes they limit or specify the statement. So again, it could be impaired gas exchange, risk for injury, ineffective tissue perfusion. That first word is just a qualifying word, and then the problem. The next two pieces of the nursing diagnosis statement have to do with the etiology, which is the cause, and the defining characteristics. So this would be the etiology. You can also think about it as related factors or risk factors, and that is one or more probable causes of the health problem. These are the things that are involved in the development of the problem. They give direction to the required therapy. They enable the nurse to individualize the patient's care. So our interventions need to be aimed at those factors which are causing the problem. And we put related to, so we would have the problem and then put related to and then the etiology or the cause. So we'll go over an example in just a moment. The defining characteristics is the last stage, and these are signs and symptoms that indicate the presence. This is how you know that that exists. So these are the factors that cause the patient to be more susceptible to the problem, and we write them as evidenced by. So a complete nursing statement would be acute pain related to tissue ischemia as evidenced by statement of I feel severe pain in my chest. That's the problem, what's causing it, and how you know that it exists. Keep in mind that different types of nursing diagnoses may have one, two, or three components based on the type. We in school will most likely always focus on a problem-focused or a risk nursing diagnosis. Very rarely at this stage are we going to be trying to manage health promotion or syndrome diagnoses, but I did want you to be aware that those exist in case you read them or see them somewhere. A problem-focused diagnosis sometimes is referred to as an actual diagnosis. So this is a problem you know exists. It's a client that has a present problem. It's present at the time of your assessment. This is based on the presence of associated signs and symptoms. Actual nursing diagnoses should not be viewed as more important, though, than risk. Risk diagnoses are often a big part of our role because we're trying to prevent future problems. A problem-focused nursing diagnosis would have all three of those components because you have the problem, you have the etiology or the reason why, and then you have the evidence. These are the characteristics, the defining characteristics that demonstrate for you why this problem exists or that this problem exists. The second type is a risk nursing diagnosis. So this is a clinical judgment. This is a problem that doesn't exist yet, but there's some risk factors there that make you a little worried and make you think you might have to intervene or should intervene to help prevent this from happening. So think about someone who's had surgery and they're unable to move around. They may have a risk of impaired tissue integrity. So you're worried about their skin, or breathing patterns may be altered because they're on pain medication. And so they have a risk of ineffective breathing. So these are you just kind of guessing what might be the problem or assessing based on where you're afraid they might end up. So you might have an elderly client with diabetes and vertigo, so they're dizzy and they have difficulty walking and they're not asking for help when they want to write. So that may be a risk for injury patient. Or you may have a risk for infection if someone has a surgical wound. In many cases, these will only have the first two parts of the nursing diagnostic statement, the problem and the cause, because they don't really have symptoms yet. So the last piece of that, the defining characteristics, don't necessarily exist. I will mention the health diagnosis or health promotion and syndrome diagnoses because they are types of nursing diagnoses, but you won't see them much in school. A health promotion diagnosis is a clinical judgment about motivation and desire to increase well-being. So this is concerned with the individual, family, or community. They're transitioning from a specific level of wellness to a higher level. So you're really about getting them better. And oftentimes a health promotion diagnosis only has one part to it. A syndrome diagnosis also may have only one part, and it's a clinical judgment about a cluster or a cluster of problems or risks that are predicted to present because of a certain situation. So it might be chronic pain syndrome, post-trauma syndrome, frail elderly syndrome, those kinds of things. And that's more of an advanced level. Right now, you're really just going to be focused on the problem focused and the risk diagnoses. So here's some examples of those, just so you've got them. A problem-focused three-part nursing diagnosis might be bathing self-care deficit related to fear of falling in the tub and obesity, as evidenced by strong body odor, urine odor, unclean hair, statement of feeling frail, or statement of fearing fall in the tub, height and weight. Obviously, it's a large person. So we've got what we think the problem is, which is they have a self-care deficit problem, and the related to is why they have that problem, and as evidenced by is how we identified the fact that that problem exists. A two-part nursing diagnosis might simply be risk for infection related to compromised host defenses or related to recent surgical site incision, or something like that. There is no infection yet, so you don't have characteristics to report. And just so everyone doesn't have to be stressed out about it, there is a list of nursing diagnoses that you can easily find online. You don't have to create these from scratch or make them up. Like I said, there were, what did I say, 244 approved diagnoses. So you can search. You have a guide that you should have purchased in the bookstore. And many of our textbooks also have sections dedicated to associated nursing diagnoses with particular conditions. So once you've got this diagnosis down, we've done our assessment, we've gathered all the data, and now we have determined a diagnosis and we've written our diagnostic statement. We've got to set some priorities because, as you hopefully remember, the next step is going to be planning. Well, in order to plan what we're going to do next, we have to kind of decide what are the most important things to focus on. When I talked about planning that party, there were probably lots of other things that might have been important, but I came up with 3 or 4 very important things. People are safe, people enjoy themselves, etc. So you have to look at which diagnoses would require attention first. And then you sort of rank them high, medium, or low priority. And the things that influence how you rank them has to do with, of course, if you have an urgent condition, something that's going on right then, especially if it relates to breathing or fever, certain things going on immediate that you have to address, those are going to take priority. But you also want to consider patient beliefs, values, what they want, what's important to them, and also your available resources. Coming up with a great diagnosis and plan won't be effective if you don't have the resources to actually carry it through. Now, I have on the screen, Maslow's hierarchy of need. You probably remember that from psychology class. That may also help when you're trying to determine and set priorities. Certainly, physiological needs like breathing and food and water, those kinds of things are going to take priority over some of the things like feeling of love and belonging. While those other things are important, they probably would not take priority. Once you've set your priority, you've got to establish your goals and outcomes. So we did assessment, diagnosis, then we did our assessment, diagnosis, and now we're ready to start planning. And in order to plan, we've got to come up with our goals and our outcomes. That's part of the planning process. So that has to do with what we hope to achieve. We recognized a problem, we want to see it get better. In order to know what to do to make it better, we need to know where we're headed. What's the target? What's the end game for us? If it's someone who is uncomfortable or in pain, I would think our target would be that they remain pain-free or at least have a lower level of pain while we're taking care of them. So knowing where we're going and starting at with the end in mind that's part of what this process is. So we have to come up with we have a desired outcome or change. We prioritize it, as I mentioned. And then goals are usually very general, outcomes are specific. And usually in nursing care plans for school, you're typically writing outcomes, but if you can't, a goal is fine. So an example of a goal, if you want to understand the difference, a goal might be patient's nutritional status will improve. It's very broad. What does that mean exactly? An outcome might be patient will gain 5 pounds by a certain date. And that's why I said in nursing school, you're typically writing specific outcomes versus more broader goals. A goal might be that patient's pain is improved or pain level is improved, but an outcome would be patient's pain level remains below 2. It's a little more specific. Goals and expected outcomes have to be measurable. You won't know if you've reached them if you can't measure them, and of course, patient-centered. They focus on problem prevention or problem resolution or sometimes rehabilitation for that patient. They can be short-term. This is what you're typically going to see in an acute care hospital setting, or in long-term facilities, they may be more long-term goals. A short-term goal is a statement distinguishing a shift in behavior that can be completed immediately, usually within a few hours or at most a few days. A long-term goal is an objective that needs to be completed over a longer period, sometimes weeks or months. So just like we had a nursing diagnosis statement, we also have a goal and outcome statement that's written in a very specific way. These are the components of that outcome statement. The subject is the client or patient. So patient will or client will or family member will. It's whatever we want to see the change in. You may also have, however, some attribute of the client. So the patient, the pulse or the temperature or the urinary output will change in some way. So it's either the patient or it's some attribute of the patient. The verb is the action or the thing that the client is to perform. So what they're to do, learn, or experience. The condition or modifiers, these are the what, when, where, and how. So they're added to the verb to explain the circumstances under which the behavior is to be performed. And then the criteria at the end has to do with that final, when is it supposed to occur, for instance. When writing goals and desired outcomes, you always want to follow a couple of tips. So you want to write goals and outcomes in terms of patient responses, not as just activities. So you're going to begin patient will. This helps focus the goal on client behavior and responses. Avoid writing goals on what you hope to accomplish. Focus on what the patient really can do or will do. Use observable and measurable terms for your outcomes. Avoid using vague words that require interpretation or judgment. Desired outcomes should be realistic, based on the resources and the capabilities and limitations of the patient, and on the designated time span. If you want it to be something that happens by the time you leave during your shift, it really needs to be the kind of goal that can be done in that amount of time. You want to make sure that the goals are compatible with the therapies or other professionals. So you wouldn't want to write an outcome statement where your patient is going to walk the hall by the end of the day and it turns out that the physician had wanted them to stay in bed. Make sure that each goal comes from only one nursing diagnosis. So keeping it this way really helps to facilitate evaluation. So you don't want to have a goal that's connected to multiple nursing diagnoses. A nursing diagnosis may have multiple outcomes, but you wouldn't want a single outcome to be associated with multiple diagnoses. So now you have prioritized, you've assessed, you've come up with a diagnosis. You've planned your care by coming up with some goals. These are the things that we want to see happen and when, and now you're ready to do something to make that happen. So nursing interventions can be independent, things that you do on your own. They can be dependent, so meaning they depend, for instance, on physician orders. So if one way that you would like to address the patient's pain is by giving them pain medication, that's fine as long as there's an order to do so. So that's a dependent intervention. Or if they need diagnostic testing or treatments or change in diet or activity, all of those things require a physician or provider order. Then there are collaborative interventions. That's something you do with other team members, social workers, dietitians, therapists. Sometimes you may have a goal that you want a patient to have a plan for how they're going to get to follow up doctor's appointments after they're discharged from the hospital. Well, that may be something that requires other people in order to put together. You're going to write your nursing interventions by putting your date. You're going to sign them. You want to be very specific with how you state them. There's that action verb. Things like your qualifiers are going to be things like how, when, where. You don't want to use abbreviations unless they're approved by an institution. The date that the plan is written is essential for evaluation, review, and future planning. So, and then of course your signature demonstrates your accountability to that plan. Nursing interventions should be specific and clearly stated, as I said, and some examples: educate patient on proper diet to reduce the risk of constipation, or assess urine for color, amount, and odor. Those are very clear nursing intervention statements. And so as you go through this process in your workshop, you will start to put together from beginning to end all of these pieces to come up with a care plan. Providing rationales is something that you'll see a lot of in school, and that's just because we want to be sure that when you're deciding on interventions that there's a reason for them. Just saying something may sound like a good idea, but it's important that you have backup data, that you have evidence to support why you're doing what you do. The nursing profession is built on evidence, but more importantly, you want to be able to justify your decisions. These are scientific explanations or underlying reasons. So as an example, if your nursing intervention is to auscultate or listen to the apical pulse, assess the heart rate, rhythm, document dysrhythmia if needed, or if they're on telemetry, the reason for that is because, again, depending on the client situation, tachycardia is usually present even at rest to compensate for decreased ventricular contractility. So you're literally saying the reason I have to watch for this is because this patient's condition can lead to this occurring. So it's important that I watch for it. So it's just kind of showing that you understand why you are doing what you are doing. Once you've completed your interventions and you're in evaluation, you should know before you ever do the interventions exactly how you're going to evaluate them. Part of that was in your goal statement, but evaluation is a planned, ongoing, purposeful activity. So you're monitoring the patient's progress towards achievement of these goals and outcomes, or the effectiveness of your interventions and plan. You can say that an outcome has been met, it's been partially met, or it's not been met. When you write that evaluative statement, that last part of this plan, it has two parts. It's the decision about how the outcome was met and the patient data or behaviors that support the decision. So I'll give you three examples of what an evaluative statement might look like. I'm assuming based on these examples, we're talking about someone who had a goal that they quit smoking. So one example is outcome met, patient reports 1 week of no tobacco use. Another example might be outcome partially met, patient reports decreasing tobacco use from 1 pack per day to 4 to 6 cigarettes per day. Continue to implement a monitor plan. And then unfortunately, the answer might be outcome not met, patient reports no change in tobacco use. So we're going to revise our goal. Revision, re-explore patients' commitment to try tobacco use control strategies and adequacy of personal support systems to eliminate tobacco use. So even when a goal is not met, it should result in a new plan that may be easier for that patient to complete. Care plans are found in multiple different formats. I'm going to walk through at the very end of this the format that we're using here, but you may see just simply a nursing diagnoses or problem list. Sometimes they're completed as care maps, and then sometimes there's just a 4 or 5 column table, 1 column for the diagnosis, etc. And the difference between those is the rationale column often, because only in the student world typically do you include a rationale. So let's walk through what our care plans look like, and then we'll get some practice in. The care plan document, you have it attached in your Canvas shell. Um, this is what you'll be doing with any of your clinical courses. The differences might be how many nursing diagnoses or how many interventions your faculty member asks you to include. That will typically start off simple, and as you progress in the program or within a particular clinical, it will progress and get a little more. In some cases, you may be asked to come up with one diagnosis in your first few weeks of clinical, add to those as you go along through the course, and then put the entire thing together to submit at the end of the course. So that will be up to your faculty. But in all cases, the care plan packet looks like this. You will have a title page, you'll complete a clinical worksheet, you'll have a page that lists out diagnostic lab and diagnostic findings from your patient, medications. You'll put some nursing diagnoses together to include interventions and rationales. You'll tell us a little bit about the medical diagnosis itself, and then journal some about your experience, and of course, a reference page. The clinical worksheet has demographics about your patient, their fall risk, allergies, if they have an IV, that kind of thing, as well as your personal physical assessment findings. If there are certain body systems that you're not assessing for one reason or another, you would make note of that. The diagnostic finding sheet just has the date of the tests that were ordered, their normal values, what you would expect to find, your patient's values or results, and then a little information about the analysis of that. Why does it matter? What might have caused it? That sort of thing. The medication sheet, you include the generic and trade name for all of their medications, the amount or dose, how often they're taking it or the frequency. The mechanism of action is just, you find that in your drug book when you're looking it up, but it's a short version of how the drug acts or what it's supposed to do. Major side effects you would have to be concerned about, and nursing interventions is really kind of what do you need to be aware of? Is there something specific you should be doing for a patient who's on this medication? For instance, if they're on a blood thinner, you might want your nursing intervention may have to do with making sure that they're not at risk of falling down because they can bleed easily, that kind of thing. Depending on your particular clinical assignment and your faculty, your clinical instructor, you may be asked to put all of the medications down. They may say just the most recently given. As you can imagine, some of your patients may have charts with a lot of medications. That's going to be up to your faculty member to decide. And then finally, the plan of care itself is a pretty straightforward table. Include each page will have its own diagnoses. So each diagnosis that you're asked to create or produce will have its own page. You include the subjective and objective data. So that's the things that you learned from their history and the things they told you were bothering them, as well as the physical assessment findings and lab data, etc., the objective things that support that diagnosis. The client goals, what you're wanting to do for them, the nursing interventions with rationales, and then the evaluation criteria, just like we've been talking about. Finally, at the very end, you'll put together a medical diagnosis sheet where you just write a few paragraphs about their diagnoses. Now, if you have a patient with multiple diagnoses, just ask your faculty member if they want you to focus on one particular diagnosis or include multiple. And you'll write up a little bit about the cause of that condition, signs and symptoms, tests, treatment, and complications. And then the very last thing is a clinical experience journal. So that's where you write a little narrative about your clinical experience, things you learned, things that happened, that sort of thing. And that's what your care plan process will look like throughout your program. The only difference will be the number of diagnoses or maybe the detail that you're asked to provide. So let's practice. Let's do one case now. Now, when we do the second part of the workshop part 2, that's going to be nothing but practice. So in between now and then, you have some chance to review these slides, go through the material, and try to do a little outside reading so that you can come back and do some practice next time. But we'll go through one simple one just so you can get the hang of it. So we have a patient this is the diagnosis that we've come up with. So this is an example of how all of this would be put together. So we've recognized that we have a patient that, for whatever reason, maybe he's had surgery, maybe he's in pain, maybe he has bad eating habits, all kinds of things. But our diagnosis is that he has an alteration in bowel elimination, constipation. Now, that's an actual diagnosis. If we wanted to make that potential, it would be risk for alteration in bowel elimination, constipation. If we think someone's headed that way because now they're taking pain medications, for instance, and we know that that can cause constipation, or they become more inactive, or they're dehydrated, that sort of thing, that would be a risk of. In this case, it looks like this is an actual. Related to, these are some examples: stress, immobility, inadequate diet, pain, pregnancy, drug side effects. I'm not saying this person had all of those things. I'm giving you some examples of some of the related to, or the etiology or the reason for the diagnosis, as evidenced by hard form stool that occurs fewer than 3 times per week, decreased bowel sounds, reported feeling of rectal fullness, straining, pain on defecation, and palpable impaction. Now, that's a pretty hardcore constipation. That's someone who has an impaction. But that's an example of some of the things as evidenced by. Evidence could also include something they've told you, in quotes. I can't seem to go to the bathroom. It's been too long since I've gone to the bathroom, that kind of thing. The care plan would be some of the plan and outcomes. So when we're looking at outcomes, what do we want to see happen? What's our end game? So we want them to have formed stool by, and you put a date in. So by tomorrow, we put that date in. And every 2 days, within 2 days after. We also want the patient and their significant other to verbalize an understanding of methods to prevent and or treat constipation. Now, there are many other goals or outcomes that we could put in, but these are, that first one is it's definitely an outcome and not just a goal, because we're going to say we want this to happen, this is how soon we want it to occur. And then what can we do to reach that goal? So how do I keep people at my party happy? How do I make sure all of those things we did at the beginning with that party? Well, let's think about that. If we want them to have these soft form stools, what are some of the things as a nurse that we can do? We can assess the abdomen for distension. We can assess their bowel elimination on a frequent basis. We can assess factors that are responsible. So what's the stress, discomfort, things that would cause potentially this not to occur, we should be assessing on a regular basis. We can promote corrective measures, so providing privacy and comfort, encouraging adequate exercise. We can promote adequate dietary fluid intake. We can initiate bowel program if necessary. We can also consult the dietitian. So that's a lot of different things that we can do to reach those goals. And any of those things could be also include a rationale for those. For instance, promoting adequate dietary fluid intake, the rationale for that would include the scientific reason behind that. What happens with decreased fluid, and how does that impact the ability to have normal bowel movements? So this is kind of how the whole process flows. In the workshop part 2, you'll be given cases to practice together and on your own, and hopefully with more and more practice, by the time you get out there in the clinical environment, this will start to become second nature. So hopefully this is something that's helped, and it's just a start. You're in the very beginning. You'll get a lot more information about this, but hopefully this will get you started in the right direction.